Thank you for the introduction, Jennifer, and good afternoon, everybody. I know it's the last one of the day, and I'm sure your brains are fried. So I'm going to be quick. It's going to be a very brief overview of some of the retinal pathologies. And I know some of you work exclusively in retina, and for those, I apologize if it's too simple or too brief. But my goal here is to give you guys an introduction to what retinal pathologies are like and what kind of stuff that we do. And I'm not going to go into a whole lot of diseases. I'm just going to focus on probably the most common ones that you encounter, and also about 2 or 3 surgeries that and as a warning, some of the surgeries, I know some of you don't like to see blood, and I'll give you a heads up so that you can close your eyes. I don't want any of you to pass out. And trust me, it's not just you. A lot of physicians don't like to see eye surgeries. All right, so let's get started here. All right, I'm going to briefly talk about anatomy. Just in structures that and the labels that we use, and quickly talk about 2 or 3 most common diagnostic machines that we use and why we use it. And then talk about a few pathologies and finally wrap it up with some surgeries. So you already heard a lot about the cornea, so I'm going to blow past it like a typical retina surgeon and dive right into the retina here. So the retina that we talk about is the inner lining of the inside, the entire inside of the retina. Inside of the eyeball is basically the neural retina. And between the retina and the sclera, you have a layer of blood vessels, which also has a lot of pigment, and that gives the color of the eye as well, which behind is called as choroid, which as you go come to the front, it becomes a ciliary body right here, eventually the iris, and then you have the pupil. Now, the macula is the part of the retina right here that lines up straight with the pupil, so that when you're looking at something, when you're reading something, you are trying to line up your fovea, which is the central part of the macula, to whatever you're looking at, so that that's where your sharpest 20/20 vision happens. That has the highest concentration of the cones that allow you to see. Now, if you were to look through the pupil with through a slit lamp or use a fundus photo, for example, this is what you would see. And that's the optic nerve, and you have the blood vessels coming up through the heart, coming out through the optic nerve, and then migrating across the surface of the retina to all the way to the peripheral edges of the retina. And again, you can see the macula, which is basically the central part of the retina, with the fovea, which is the dark pigmented spot in the center of the macula there. A simple way to look at or identify the macula would be to look at these blood vessels, and it'll be within those blood vessels there. And for orientation, this is the left eye, and this part of the retina is towards the temple, so it's temporal, and nasal to the disc towards the nose would be the nasal, superior and inferior. If you were to take a cross section of the retina and then look at it, and this is what you would see. You have your rods and cones right here, which the cells of those rods and cones are accumulated in this layer. These connect to the bipolar cells through the synapses in this part, and the bipolar cells connect to the ganglion cells through the synapses here, and the ganglion cell nerve fibers then migrate along the surface of the retina back to the optic nerve and back to the brain. Now, the retinal the rods and cones, if you magnify this part right here, the rods and the cones are integral or interact with the retinal pigment epithelium, which wrap around the outer segments and then recycle all the discs and the biochemical molecules that are necessary for vision. And so this is a process that's constantly happening, and you need to have that interaction for the retina to survive. On the other side of the RPE is the choroid. And that's right here. And if you magnify it, you can see the choriocapillaris right here. So of course, the nourishment from the blood flow travels across to the RPE and eventually to the retina as well. So that's the cross section of the retina, and we would have to wait for somebody to donate the eyes to be able to see all that. But these days, we have the OCT, the optical coherence tomography, that allows us to get these sections of the retina in a live person in a very non-invasive way, very painless way. And you can actually make out many of the details from the section. For example, that's your rods and cones nuclear layer, which is what this layer is. And that's your bipolar cell layer, which is right here. And then you can see the nerve fiber layer right here, a little bright white layer on the surface here. Now, this bright white signal right here, that's the RPE, and all these other lines in between are the rods and cones, outer segments and inner segments that are interacting with the RPE. You can also see the choroidal blood vessels here in these dark spaces here. So when you see this as probably one of the most common diagnostic tests that we do, and the best way to differentiate the subretinal space is to look for this brightest line on the closest to the choriocapillaris, and that would be your RPE, and anything above the RPE would be the subretinal space. Now, that is a potential space that disappears once the eye is fully developed, but could reopen in say retinal detachment, for example, and we'll go through that in a second here. The other diagnostic test that we use commonly, or at least not as much these days, but is the angiogram, where you get to look at not just the large blood vessels, but also the tiny capillaries as they dive into the deeper tissue. And the process involves injecting a fluorescein dye into the vein. And as it travels through the blood vessels, we take a series of images very quickly and map out as the blood or the dye flows through the blood vessels. And you can get a fairly extensive detail through here. For example, you have the optic nerve right here, but you can see a small area where the fovea is, like a dark spot, where there are no capillaries, and shows up as a dark spot, but the rest of the blood vessels light up as the dye flows through it. You can also see where there is no dye flowing through the tissue because there's been an extensive loss of capillaries, and that shows up as capillary non-perfusion areas. Or if you have an abnormal blood vessel, a neovascular tissue that's growing, you can see this as a beautiful fan of a network of blood vessels in the periphery right here. And some of these leak. And so when they leak, the dye comes out and it's very bright and easy to pick up that leakage. And these kind of detail may not be easily evident, or at least directly visible when you look inside. And so the angiogram becomes a very crucial diagnostic test. And if you zoom into the fovea, you can see the beautiful network of capillaries. And this kind of detail, there's no way you can get that clinically. Just by a simple exam, and hence the angiogram becomes a crucial diagnostic test. Again, these days we can do the same thing with an OCTA without injecting the dye and all the complications that come with the dye, which is basically itching, nausea, and vasovagal reaction, and sometimes even severe allergic reaction. So the OCTA does not involve injecting a dye, but you just map out the blood vessels, and you could potentially pick up any dropouts or any destruction of those capillaries, but you will not be able to detect the leakage that you see with the angiogram. So I'm going to switch over to some of the pathologies. So one of the most common diseases that we see in America is the age-related macular degeneration. Again, most of the pathology happens in the macula, and hence it's macular degeneration. And because aging is the biggest risk factor we label it as age-related macular degeneration. And it's usually characterized by these yellow deposits that you see, the drusen, which is deposits of debris under the RPE that show up as small mounds of yellow spots. And that's what you see in the early stages, especially large drusen, along with some changes in the retinal pigment epithelium. Now, this may start in your 50s, 60s, although the formation of drusen is just a normal aging phenomenon, but it's just the degree and the extent of the drusen that you see that differentiates a normal accumulation of the debris from a pathological condition. And then over the years, as more and more of the tissue, surrounding tissue starts to thin out, you could start to see loss of retinal pigment epithelium. And that shows up as these areas where you can actually see the RPE is absent, and you can see the underlying choroidal blood vessels like here in this image. And that for a patient is basically a dead spot, and they're not able to see through that. They can see the rest from the rest of the rest of the retina is working fine, but that area is a blind spot. And if it happens to involve the fovea, you can imagine how profound the effect it has on the vision. Now, in some patients, you could have abnormal blood vessels that start to grow in from the choroid into the retina and start to bleed. And that would be your CNV, or the macular new vessels. That would lead to a fairly rapid change in the vision, and patients notice a big a shift in the vision with a big blind spot and perhaps even distortion. And that would be your wet AMD. And currently, the treatment for the wet AMD is basically, in the early stages, we just use the vitamins to kind of slow down the progression of the degeneration. It's a very small effect, but it's that was the best thing that we had for almost 20 years. And we still continue to use that in the early to intermediate stages, using a high concentration of vitamins C, E, zinc, and lutein, and zeaxanthin. That's the AREDS2. Helps to slow down the progression of the macular degeneration. But once you get to the wet macular degeneration with the new blood vessel, the current treatment often involves intravitreal injection of anti-VEGF agents. Basically, these blood vessels are growing because there's an excessive production of vascular endothelial growth factor as a reaction to inflammatory changes in the macular area. And so these injections are basically antibodies that block that signal, and without that signal, the blood vessels shrivel up, and then the CNV slows down, and there's not as much leakage. Unfortunately, most of these injections last a certain number of weeks, and so we end up repeating the injection over and over again, and hence you have your clogged up retina clinics and clogged up OCT machines. And over the years, we've had several of these injections. Avastin was the first one that we used to use, and the latest one is the Vabysmo. And hopefully, we'll have more long-term or implants that can last for several months. And in the future, maybe we don't have to do these injections as often. But the bottom line is that it's an ongoing treatment that goes on for pretty much until the patient expires. But one thing to know is that these patients don't go completely blind. They just cannot see centrally. And so it's not as debilitating as, say, retinitis pigmentosa, for example. And for the dry macular degeneration, we just got one of the new medications that has been approved, basically blocks or at least slows down the inflammatory component that helps to feed the destruction of these cells. It's just out, and I don't think we've used it yet in our department, but hope to soon. Diabetic retinopathy is the other big one here. And basically, it doesn't matter how good your sugars are under control. at some point, say 10, 20, 30 years later, you're going to have some manifestation of the diabetic retinopathy. Here, the pathology is different from the macular degeneration. It's the glucose levels, the elevated glucose levels that tend to damage the lining in the capillaries. And so the capillaries become weak, they start to balloon out, and they start to allow blood to leak out. And so you start to see manifestations of that, which could show up as microaneurysms. You could have dot plot hemorrhages. And if there's extensive leakage, you could have swollen retina. And if the swelling involves the fovea or the macula, it starts to affect the vision. And the other part to remember with the diabetic retinopathy is none of these things, if it's not affecting the vision, the patient doesn't know that they have all these changes going on. So they could be walking around as if nothing's happening, and one fine day they could end up with a big change in the vision. And hence the recommendation that whenever you have a diagnosis of diabetes, make sure to get your eyes checked regularly, at least once a year. And as soon as you start to see these changes, see the doctor more frequently. And as soon as you start to see edema or other manifestations that could potentially lead to vision loss, then you start to get the treatment for that. So the treatments, here's an example of the microaneurysms leaking in the fovea, and you can see the dye oozing out here. So that would be your diabetic macular edema. Now, if there is continued loss of these capillaries, you end up having these large swaths of retina that are not getting adequate blood flow. And so in response, the body tries to create new blood vessels, and that would be your proliferative diabetic retinopathy. And you can see the extent of these new blood vessels completely different from a normal retina there. And the reason why we worry about these blood vessels is because they are a lot more delicate than normal blood vessels. They bleed. Then you can see the vitreous hemorrhage here, and you can see the hemorrhage is kind of settled down in a boat-shaped manner down below the macula, and you can see in the cross section of the OCT the blood particles hovering above the retina. Then, and then when these blood vessels become scar tissue, they're going to contract. They'll start to pull on the retina and could potentially cause a detachment. Here's an angiogram of the proliferative diabetic retinopathy, and you can see an abnormal blood vessel on the disc called the neovascularization of the disc, and you can see numerous neovascular tissue in the periphery. We call them as NVE, or neovascularization elsewhere. It's just a mere classification, but the treatment for the proliferative diabetic retinopathy is usually to make these blood vessels shrivel up. And to do that, you could laser all these ischemic areas where there's no capillary flow, and that's the pan-retinal laser photocoagulation. And when you take away all these ischemic areas, the amount of VEGF that's being secreted goes down, and these blood vessels, abnormal blood vessels, won't have the signal that's feeding them to grow. So the blood vessels shrivel up. Of course, you could also achieve the same with intravitreal injection, because you do have anti-vascular endothelial growth factor medications that you can inject. But the downside, of course, is you got to keep injecting until these things have become completely scarred up. And the other injection that I forgot to mention for macular edema is the corticosteroids. So you take care of the inflammatory component, and you inject basically corticosteroids into the vitreous. And one of the preparations is a 3-month-long implant, the Ozurdex, which some of you may have heard of or seen. Moving on to the vascular occlusion, usually there are 2 different types. The artery occlusion is almost quick, instantaneous. You see a big change in the vision, patients almost like having a stroke in the eye. And you can see here the white outline of the retina that's not getting adequate arterial flow. And you can see that in the angiogram, there's no dye flowing through this part right here. And you can see the distinct cutoff in the circulation. And that's how the artery occlusion happens. And this is a branch retinal artery occlusion. Unfortunately, there's no treatment for that. That has been proven to reverse it or improve it. Oftentimes, we have to figure out if this is a process that's going to affect the brain, and so hence the urgency of trying to figure out if the patient is about to have a stroke and do a stroke workup, and to rule that out. And relatively more benign compared to the artery occlusion would be the vein occlusion. And here it's mostly related to age, but sometimes it can happen in young people because their blood is too thick, or perhaps they're on medications that making the blood develop some clots, or perhaps they have a genetic abnormality that leads to clot formation. Regardless of the mechanism, when there's a vein occlusion, the blood's not flowing out of the retina. It gets backed up, bleeds out, and you can see all the blood seeping out into the retina. And then if you do an angiogram, you can see there are areas where the capillaries are destroyed. So you'll also end up getting ischemia. And if the central vein gets obstructed, then you can have these hemorrhages throughout the retina, which then becomes a central retinal vein occlusion. Again, depending on the extent of the damage, you could just have a little edema or no edema at all. If there is edema, the treatment, again, is the same because the underlying element is the excessive production of vascular endothelial growth factor. And so blocking that helps to relieve the edema. The nice thing about the vein occlusion is that our bodies do try to heal up. They try to make new blood vessels, and eventually they might reestablish the circulation so that you don't have to keep on giving these injections forever. But in some cases, it can be a long-term process simply because the extent of damage is too much for the eye to heal up. Again, same anti-VEGF injections and steroid injections. Here's an example of the ischemic areas again. And here's a pretty bad vein occlusion. You can see there's pretty much no circulation except for this part right here. And this patient ended up having blood vessels growing even in the anterior segment, ended up with a neovascular glaucoma that required a tube shunt, and you end up having to go back in and then do laser all of this off. And obviously, this is not an eye that's going to see well. The other common one that almost everyone or each one of us will go through at some point in our life is the vitreous detachment. And the vitreous is basically the gel that's filling up the inside of the eye. It's most tightly attached to the optic nerve, maybe a little bit to the fovea, and then also to the lens in the front. And so as we get older, somewhere in our 40s, 50s, the vitreous starts to break down, starts to shrink. And as it shrinks, it starts to pull away from the macula and the optic nerve. So initially you might see that adjacent to the fovea, the vitreous starts to detach. Eventually it breaks free from the fovea, keeps shrinking, and eventually breaks away from the optic nerve. And that's when patients often notice a bunch of new floaters. They might notice a bunch of flashes, especially in the periphery. But when this happens, sometimes it can tear the retina too. Or the vitreous may not separate out quickly. In fact, it might start to pull on the retina because it's too adherent to the fovea. And that's when you would see the vitreomacular traction, and you can see the fovea getting stretched. And if there is too much stretching, the patients might start to notice a change in the vision, or if it ends up with a tear or a hole in the retina, a full thickness retina macular hole, then there's a decline in the vision. And this becomes a situation where you would have to operate to close up that hole. And so the consequences of vitreous detachment would be nothing, just floaters, or sometimes you could have epiretinal membrane, you could have a full thickness macular hole, or vitreomacular traction. But in cases of epiretinal membrane and a full thickness macular hole, if they are causing problems to the vision, then become we often do a vitrectomy and a membrane peel to help to alleviate the symptoms. And this is the part that if people who are squeamish can look away. So the vitrectomy involves putting in ports, and this is what we call as a 3-port vitrectomy. Basically, you have 25 gauge ports that are created. One of them will have an infusion going in, inflating the globe so that the globe doesn't collapse when we are doing the surgery. The second port will have a light pipe so that you can illuminate the inside. And the third port will have the cutter, which is the main instrument. And the vitreous cutter is basically a combination of a cutting and a vacuum instrument. And it's taking small bites, vacuuming a small amount of vitreous, cutting it, and then grabbing another small bite of vitreous. And this is happening at a very rapid rate, almost 10,000 cuts per minute. In this way, you're not pulling or tugging on the vitreous and causing more trouble. So once we create the port, we put in a microscope and then use use a catalog. Use a catalog to highlight the vitreous, so that, because remember, the vitreous is kind of translucent. So in order to highlight the entire vitreous, we use triescents or catalogs, basically steroid particles that bind to the fibers of the vitreous, and we can and then go about and removing all of the vitreous. So that's the first step in any vitrectomy, is to remove the vitreous. And then once we finish the vitrectomy, then we try to grab the epiretinal membrane, which is again a very translucent tissue, and it's almost impossible to see, but you can kind of see the glistening membrane that's coming off there. And so that's the epiretinal membrane that's being peeled off. And once that's done, what we do is we like to highlight the inner limiting membrane, and especially in patients who have a macular hole, simple removal of the membrane doesn't allow the hole to close up. So we actually peel the inner limiting membrane. But because it's a transparent and very thin tissue, we highlight that with brilliant blue, and so you can see the outline of the ILM here. And we peel the ILM off of the macula, so that way any remaining wrinkles smoothen out, number one. And number two, it allows the macular hole to close up. And once it's done, say for example in a macular hole, we would fill that up with a gas bubble, and the gas bubble was going to push up against the retina, and the surface tension of the bubble will help to squeeze the retina together, so that the hole approximates and closes up. Here's the other consequences of a vitreous detachment, a retinal tear. This would be a horseshoe retinal tear, and you can pretty much see the outline of the tear there with a little bit of subretinal fluid, and you can see the outline of the fluid right there. And the importance of this is that if you don't do anything, the fluid will continue to accumulate, and then the retina will start to detach more and more, and eventually extend up to the fovea and the rest of the retina. And hence, we try to laser that off in the clinic, basically create a chorioretinal scar or scar tissue around it, and wall it off so it doesn't spread. But if it does spread, or it could end up with a big, tear right away, so it'd be a giant retinal tear. But if you do end up with a detachment, we would call that as a rhegmatogenous retinal detachment, to differentiate it from the other types of detachment that can happen, which, for example, could be from a diabetic scar tissue that's pulling on the retina, so basically a tractional retinal detachment. Or sometimes you could have an inflammatory process or a malignant process that's oozing fluid that accumulates in the subretinal space and leads to a detachment. So here are a couple of examples of a rhegmatogenous detachment. You can see the extent of the detachment right here. This is more extensive in this one on the right. And here's an example of a diabetic tractional retinal detachment. And you can see the extent of the scar tissue that's sitting on top of the retina, contracting it and pulling it up. And that's highlighted here in the OCT. You can see the thick scar tissue on the surface of the retina there. Here's another example of a combined traction and rhegmatogenous. You can see a little tiny hole right here and a bunch of scar tissue on the surface, causing the retina to bunch up, causing the retina to detach. Here is an example of a malignant tumor shown here with the dotted line that's causing fluid accumulation and leading to a serious retinal detachment. And to treat the rhegmatogenous retinal detachment, basically the principle is to close the tear, drain out the fluid. As I said earlier, if it's just a tear, you could laser that off, or you could even freeze that and create a scar tissue. Or you could do a pneumatic retinopexy in some situations where if it's a small area of detachment, especially severe, with a single tear, you can inject a gas bubble, float up the gas bubble to cover that tear so that more fluid doesn't go in. And whatever fluid that's there will get reabsorbed. The other three options would be to put a buckle, support the tear from outside and drain the fluid, subretinal fluid from outside. Or you could go inside into the vitreous cavity and do the surgery. And I'll show you a video of that towards the end. And of course, you could combine all these procedures. So here's the example of a retinal detachment surgery where after the first step would be to do the vitrectomy. And you can see the bullous elevated retina there, but in order to flatten it out, we use this heavy liquid called the perfluoron. When we inject it, it kind of steamrolls the subretinal fluid out from under so that the retina starts to flatten. And you can see that it's already starting to flatten out there. And once the fluid is drained out, we like to laser those areas where the tears are, where the holes are. And that's what you see that here. And once that is done, now that the retina is nice and flat, we're going to remove all the fluid at the next step. And that's the air fluid exchange. And the point of that is that the laser doesn't seal up the holes right away. And you don't want the fluid to go back in and cause a recurrent detachment. So what you end up doing is removing all the fluid and then fill it up with the gas or an oil bubble so it stays as a bubble as opposed to a fluid, and it doesn't flow back into the subretinal space. And over the 3, 4, 6 weeks, if you use a gas bubble, the laser becomes scar tissue, nicely sealed up, and the body reabsorbs the gas bubble, and you're hopefully back to where you were. If it's an oil bubble, the body doesn't reabsorb, so you have to go back in 2 months, 3 months, 6 months, whenever, go in and remove the oil bubble there. And of course, with the gas bubble, one of the biggest worries is that if you go to a higher altitude or go flying, the gas can expand and patients will end up having severe elevations in intraocular pressures and could potentially be blinding there. All right, so here's the post-op. This is a case of rhegmatogenous retinal detachment. You can see the tear, you can see the extent of the detachment. Here's a cross-section of the retina on OCT. And post-op, the retina is nice and flat, has some small spaces, cystic spaces, just a little thickening there, and a little epidermal membrane, which is a thin line that you see on top. And that's our retinal detachment repair there.